All right, everyone, we'll get started. I know there's some people still coming. It is so exciting to have Dr. Dave Wyles back with us. Clap, 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 right? Clap. Who we miss, who we miss so much. But it's really nice to have you here. And in the spirit now of us, you telling a little bit about us.
This is more. This is making me more nervous.
I know. We've all had to do it now, but this is Davey's way of starting. So you'll be fine though, I'm sure. So can you tell us a little bit about your path from the beginning to where you are right now? Not like birth, you know.
I got it.
A little
Skip
further.
a little bit.
Yeah.
So I grew up in rural Ohio.
Oh wow, you really went back.
There.
Med school. I jumped to med school.
Jumped to med school.
Yeah,
okay.
yeah.
Northwestern med school, Chicago.
Yeah.
Thought I was going to be an orthopedic surgeon.
There we go.
Worked in biomedical engineering and biomechanics. Orthopedic surgeon, got on my rotations and realized when they didn't even want to talk about managing insulin and other things like that, that it was not quite detailed oriented enough for me. Then I ran into John Fair at Northwestern. He was a very big influence early. I rounded with him when I was a second-year medical student, I think, there was a case of Legionella. He started talking about hyponatremia, GI symptoms, and how they knew this was Legionella, and I was in from there, I think. And then I migrated further west, went to Colorado. I had to think first.
I know. I
ran into this guy.
Like,
I ran into this guy. I don't want to. I'm going to
And this guy means Dr. Chip Schooley.
Yeah.
People are listening.
Yes. So as I was finishing residency, I was interested in Hep C. Talked to Chip. He had just finished leading the ACTG and was ready to take a chance on a fellow again with him. And so he conned Tom Campbell into letting me go into the lab and work with one of the postdocs and work on some RNA for hepatitis C. And we got an in vitro replication system going. And just as I was junior faculty or instructor, got a good score on a K, didn't get it first, and then we came to UCSD and got the K shortly after, and was here for 12 years, I think, about. And then just have been back in Colorado about 2.5 years now, not even quite 2.5 years.
And what do you do? Yeah, what are you doing there?
So I'm at Denver Health, which is the safety net hospital in the University of Colorado system. It's one of the affiliated hospitals. And I'm still doing hepatitis C stuff. I'm not doing drug trials really anymore, very little. But went back. One of the things was I know the people there, I like the people there, but it was an opportunity to work in the types of populations we need to focus on for hepatitis C elimination. And so I'll talk a little bit about some of the stuff we're doing today there in terms of corrections populations, persons who inject drugs, homeless, that kind of stuff. So that's what we're involved in there, mostly with Hep C and dabbling in some other things.
That sounded like a great segue, but I had 2 more questions for you.
Geez.
Which were,
I'm taking too long on these questions.
No, I hope we're okay. What keeps you going every day? What keeps bringing you back to all this stuff? That's the tough one.
Well, so there's, I guess, a little bit of anger sometimes when I see the troubles we have and how hard it is for us to treat our patients. Both kind of treat them as human beings sometimes, I mean, I think, in our system. And then just the frustrations we have with sometimes being able to give them the care we want to give or think they should get. I think that's a big thing. And then stepping into some of a more administrative role, I do think the people you work with, and we have a pretty young division over at Denver Health, seeing some of the stuff they're trying to do. Denver Health's very mission driven, and trying to help them along with the things they're trying to do, whether it's looking at how do we treat for bacterial infections in this population? Can we do outpatient treatment instead of keeping them in the hospital? All those kind of things. The people that work with me are the other things that keep me going.
So nice. And what do you like to do for fun?
What do I like to do for fun?
Yeah.
So we just finished ski season, although it's still going out there. So Jonathan, my son, is quite the skier now. So I try to keep up with him, and I can't anymore. He's already faster than I am. I'm getting old and more scared now. And then hiking and backpacking and stuff like that, I would say.
Thank you.
Part of the draw to go to Colorado.
Great. Take it away.
Okay, we'll take it away. Hi, everybody. Good to see so many familiar faces. Dr. Kachai, how are you? All right, so I'm going to try to talk today about a hepatitis C elimination. So this is something that has been brought up. The WHO has some guidance on what our targets should be. It's a daunting task, though, as we start to go through it. And I'm going to start off, well, these are my disclosures. Not much. We have an investigator-initiated study from funding from Gilead at Denver Health, but nothing else. So I'm going to try to set the stage for elimination, talk a little bit about hepatitis C epidemiology, I'm just going to spend maybe 3 or 4 slides on what I guess might consider are some of the advances in just the last year or so, what's changed in DA therapy. I'm not going to go through it all. You guys know most of this. I was asked to talk about this at an AASLD meeting about whether resistance was going to be an issue in terms of our efforts to eliminate hepatitis C. So I'll go through that a little bit because I can't give up resistance yet, even though it probably doesn't mean a lot in hepatitis C. And then I'll talk about where we are with elimination globally, look at the global cascade, give some local examples of what we call micro elimination. So populations or areas of the world where they've done tremendous work in a very short period of time towards elimination. And then I'll come back home to the United States and show where we're not doing so well, and what are some of the key populations we need to focus on domestically to try to make a dent. So elimination, can we really treat our way out of this? So here's the global prevalence, about 70 million persons chronically infected or RNA positive with hepatitis C. The color coding is just the estimated prevalence in different areas. You can see some of the hotspots. The United States, we're somewhere around 1%. The actual number that are chronically infected varies depending on the study you look at and whether you include some populations that are typically missed, homeless, incarcerated, et cetera. So I think it's probably higher than 3 million still, slightly here in the United States. And then genotype. So the types of hepatitis C, there are now 7 major genotypes or recognized genotypes and 8th provisionally identified. There's a lot of diversity in hep C. This is something I'm going to come back to because we start talking about global elimination. You'll see all the registrational trials were done in North America or Western Europe, and that doesn't tend to capture some more unusual genotypes or what we would think of as more unusual. And there's a few that turn out to be potentially problematic with our DA therapies, even some of our pangenotypic therapies. So I'm going to highlight that just briefly in one section a little later on. So elimination, let's just set the stage here and what we're talking about. Sometimes people use elimination and eradication interchangeably. It probably really should not be done. So elimination is reduction to 0 or some low predefined threshold. And that's really what we're talking about hepatitis C. We've kind of arbitrarily set what we're going to call elimination in incidence and prevalence. And then it can be in specific geographic regions. And it requires ongoing interventions. So it doesn't mean it's completely gone, right? And polio is probably the classic example. We would have said measles, right? In the United States a decade or two ago, but probably going to be removed. It was considered eliminated at one point. And then eradication, right, it's gone completely essentially from the face of the earth. You don't need to have ongoing intervention. Smallpox is the classic example here. You'll notice all these are vaccine. We have vaccines for these. So hepatitis C would be really the first disease we would try to eliminate through treatment. Guinea worm and things like that we're close to eliminating or have effectively eliminated, but there are then public health interventions, sanitation, and different things you can do where, again, hepatitis C, we're really talking about trying to treat our way out of this. There is no vaccine. So this is what the WHO had come out with for the 2030 targets. So these dotted lines are meant to be a rough estimate. I'll show you an update, and there has been progress. So instead of somewhere less than 10%, some of the recent estimates may be about 20% of hepatitis C globally has now been diagnosed, but we're still far away from the 2030 target of having 90% diagnosed. And then from there, it follows on, obviously, reductions in incidence by 80%. That would rely on treatment again and prevention measures. Have 80% treated, and then a 65% reduction in mortality related to chronic hepatitis C. So if you do this and this, you will pretty clearly reach that last bar, but it's obviously the first couple that are the problem. So what it is about hepatitis C replication or life cycle that makes elimination possible? And again, I think most of you here know this, but I'll do the standard contrast to hepatitis C and HIV. So it's hepatitis C, our little hepatocytes here. Almost all the viral burden is in the hepatocytes, although some transplant studies when you have an anhepatic phase suggest there is a little bit that's probably either stuck to a cellular reservoir and has a slow off rate, so it's stuck on and comes off, or may actually truly infect PBMCs or other things. Short half-life, you get new infected hepatocytes, and the whole kind of cycle of virion production into the serum, infecting hepatocytes probably takes somewhere around a week. And then once you have an infected hepatocyte, how long that hepatocyte survives, it's probably on the order of several weeks, if not maybe months or more. But I'll show you a slide just recently presented from one of our ACTG studies that pretty clearly demonstrates in the liver that you can cure hepatocytes, right? You give them DA therapy, and this is, I think, has been generally accepted, but not really proven, that you're essentially just eradicating the virus from within the hepatocyte. The hepatocyte doesn't die or need to be killed for that to happen. HIV, very different, obviously. You guys all know this, but the big issue with HIV, let's go through this, is this long-lived latent reservoir. The half-life, at least to me, somebody that's not intimately involved with HIV research, seems to get longer every time they try to look at how long it might live. So this is from a paired liver biopsy study. So this was a sub-study of our ACTG 5329. So this was just a co-infected trial looking at the old paritaprevir, bidosphero ritonavir. Sorry, I'll use the Vicura regimen just so people know that's probably somewhat a little more known. And a biopsy was done at day 0, right before they started dosing, and again at day 7, a liver biopsy. And Ashwin Balagopal at Johns Hopkins then does single-cell laser microdissection of the liver tissue and pulls out single hepatocytes. And then digital droplet PCR to look at the amount of HCV RNA inside single hepatocytes. And so at baseline, here's the distribution. There were 5 patients that had this dual liver biopsy, roughly 200 to 300 hepatocytes per time. And so in individual hepatocytes, this is a log scale. Most hepatocytes are somewhere between 10 to, sorry, this is not log, well, it's logarithmic list, but these are ordinal values, 10 to 100 HCV RNA copies per infected hepatocyte. And this is the distribution. Again, you can see there are a couple extremely high producing cells, 10,000 or more. And then 1 week later, this is the second biopsy. So you can see everything contracted in terms of the number of hepatocytes that were positive, but the expression per hepatocyte really didn't seem to change much. So there were still a few hepatocytes that were very high expressors. And that was a little bit surprising, I think, to us when we saw this data. I think people expected it to contract down and be very few. So both, but there are still some high expressors. We're very interested to see if those happen to have baseline or have resistance mutations in them now. Whether they did at baseline or not, we probably won't know. We won't, because we won't know those exact hepatocytes. And then percentage-wise, you can't read this too small, but at baseline, somewhere around 30% of hepatocytes appear to be infected. And that's been estimated before. And then a week later, you're down to less than 1% of the hepatocytes left in the liver are still infected. So the absolute decrease is over here. So it's somewhere on the order of 25, 30%, 25% when you average it all. But the relative decrease is well over 95%, right, of the infected hepatocytes seem to be gone just after 1 week. And so then if you just take this and kind of plot it out, say, okay, how long do we need to treat till they're all gone in the liver? And again, mathematical modeling from purely based on serum measurements of HCV RNA had estimated this, but this is the first time we could take intrahepatic data. It still comes out to about 2 months for most patients, and you should have eradicated everything. So we've known this, that we had some buffer built in with a lot of our 12-week regimens, and now we have many 8-week regimens. So that was, I think, kind of an interesting thing to really look detailed in the liver, something Chip had been talking about doing for 15 years ago, but you know, we got there eventually. Yeah. So what are the key updates in DAA treatment? So one place that we still need some data has been in genotype 3 infection when we use valpattizfir sofosbuvir. It's one of the pan-genotypic regimens. The guidelines for a while had recommended if somebody was treatment experienced or had cirrhosis, you consider doing resistance testing. And if they had certain resistance mutations, add ribavirin. If they had both those negative predictive factors, just starting off with ribavirin. But this was a randomized trial that looked at cirrhotic patients with genotype 3 and randomized them to just the standard 12 weeks or adding ribavirin up front to answer this question. And you can see a higher SVR rate if ribavirin was added up front, a viral relapse rate. So this is excluding or just looking purely at those that had virologic failure, lost to follow-up, other things taken out. You cut it about in half. And then if you look at the patients that actually had baseline resistance, only 84% SVR when you omitted ribavirin and 95% SVR in the population that had ribavirin. And there were about 16 or 17 patients in this group that had resistance, and I think there were 22 there. Most of it A30K or Y93H. If they didn't have resistance mutations, it was 96% in this group and 99% in the ribavirin group. So maybe even suggesting, just in the cirrhotic patients without resistance, ribavirin still maybe hanging on and have some role. I just show this as a background. Glucapavir pibrentasphero GP was one of the most recently approved. It has a very broad 8-week indication, right? For all non-cirrhotic patients, we give 8 weeks. Genotype 3, they also have to be treatment naive. And so it's a broad 8-week indication. If you would have asked me a couple years ago, 8 weeks versus 12 weeks, is it a big deal? I probably would have said, I don't think it really is. But we do find that we have significantly more success in some of the difficult populations, at least getting them to their first refill. And if we're doing a 12-week regimen, getting that third refill seems to be problematic for whatever reason. So I do feel like we get better completion rates with 8 versus 12 weeks. That's anecdotal. But this is the update. So there was what's called the Expedition 8 study that looked at now 8 weeks in cirrhotic patients. This was presented actually end of last year at AASLD. So they took all genotypes. They added the genotype 3 arm later. But 8 weeks for cirrhotic patients, compensated cirrhotics, interestingly, they used a FibroScan cutoff of 14.6 kPa. So they were pretty aggressive. I mean, I think they really did have a cirrhotic population, couldn't be decompensated. Almost all genotype 1, interestingly, even though it was largely a North American study, I don't know how they got almost 50% were genotype 1B. And I think that is a caveat here. 1B responds much better, particularly PI-based regimens. So, but the results are hard to argue with. In intention to treat analysis, it was 98%. Those were all lost to follow-up and early discontinuations. There were actually no virologic failures in this study. So if you just looked at the per protocol analysis, it was 100% SVR. So we haven't seen the FDA indication change yet. The guideline indication will change, and that'll be recommended for everybody. And we're eagerly awaiting the genotype 3 data to see what that shows.
Sorry.
No, go ahead. Oh, I could repeat.
What's the cost difference between 8 weeks and a 12-week regimen?
So if you just look at the AWP or whatever they call it, I mean, GP is pretty aggressively priced. I think it's about $10,000 a month. I'll look at Lucas too, 20 for an 8-week course, somewhere in there. So $10,000. I mean, if you're paying that, which, although we seem to be closer to the retail price for this since it's cheaper, but not pennies. So I'm going to go pretty quickly through this, but I'm going to start with the patient. So this is one of our patients in the clinic, African-American gentleman, hypertension, BPH, rheumatoid arthritis, and hepatitis C 1A. He is compensated cirrhotic. He's also on a PPI, on low-dose prednisone, hydroxychloroquine, sulfasalazine for his RA. He got 12 weeks of glucoprevir pibrentasvir. He never suppressed. So at week 4, he was 55. At week 8, he was 98. I always ask people if anybody would have stopped there at week 8 with a 98. There's no guidance there. It doesn't look good. I knew he was probably going to fail, but we kept going. By end of treatment, he was at 25,000. So he had a clear breakthrough. We thought he was compliant with his medications. And then he had clear 4 weeks later, he was up to 400,000. Being the person I am, I still sent off resistance testing, even though I'll tell you it probably doesn't matter when you retreat him. So I just wanted to know. And so he did have a high-level protease inhibitor resistant mutation, A156T, which causes high-level resistance to both of the protease inhibitors you'd look at for retreatment. He had dual NS5A variants as well. Not a lot of data on this specific dual variant in terms of what it might do, but pibrentasvir doesn't seem to, at least each single doesn't seem to cause significant resistance. So he's probably got he's got PI resistance to everything we would have. He's probably got some NS5A resistance. I think how much is unclear, and again, what it means is unclear. So what is multi-resistant hepatitis C? We're going to say 2 classes. Typically, it would be NS5A plus something else. That's mostly going to be protease inhibitors. We really almost don't see 3-drug class. I'm going to come back to this issue. Like I said, I'll talk about genotype 3 globally and some of the subtypes that may be more problematic. And then there's obviously clinical resistance, which just means your patient fails. And that has to do with a lot of things. Our patient was African-American. He had cirrhosis. It's not a PPI. We don't think that it impacts levels of GP. We don't think it really impacts the clinical efficacy, but maybe that was a component of this as well. And does this mean anybody's not curable? I thought I'd just show again, as we start talking globally about elimination, think about the failure rates in registrational trials are very low. Virologic failure rates, particularly as you come down to soft valpatisvir and glucoprevir pibrentasvir, generally are in the range of maybe 2% in clinical trials. Depends on the population you look a little bit at. The target cohort, which is a consortium of kind of real world treatment, looked at their failure rate in DA therapy. And so we see it slightly higher as you come out of trials, but not significantly higher, at least in this population. It was about 6% failed. And they were the people you'd expect. They had genotype 1A, they had cirrhosis, they were men, and decompensated cirrhosis. So it's the populations you'd expect. Now, again, this is still academic university centers, probably not the same population we're treating now at Denver Health. So I'll show you some data later of real world, if you will, persons who inject drugs, homeless populations, where it gets higher. I mean, you have to expect it gets higher. It's still very good, but it gets higher. I'm going to skip this, but just talk. So the WHO had estimated about 3 million persons had been treated for hepatitis C in kind of the DA era at the end of 2016. So from 2015 to 2016. So if you take a 10% failure rate, that's about 300,000 DA failures. And of those, about 90% have resistance. So you're still talking, 250,000 DA failures in just kind of a year and a half time. So there are going to be sizable numbers globally, percentage-wise, maybe not a large, but absolute numbers, there's going to be a lot of DA failures. So I stole this image from Chip. I think this was when he was talking about HIV eradication, maybe, and cure in the latent reservoir. Yeah, I was going to ask if you were driving or not. But so this was the picture I put up. Is DA resistance going to sidetrack us on HCV elimination progress here? I already alluded to this. I won't spend time here. Almost everybody that fails with an NS5A inhibitor has resistance there, and they stay around for a long time, despite no integrated form, etc. And particularly with these two, and particularly glucocorticoid preventative, very few people fail. But if they do, they tend to have very complex resistance patterns, multiple NS5A resistant variants, deletions, certain deletions in codons, and again, dual resistance to protease and NS5A. I will say again, the virologic failure rate, if it's a treatment naive population, is probably less than 1% with GP in at least the registrational studies. Almost all these failures were realized from retreatment studies, retreatment of prior other DA failures is where almost all these virologic failures came from. There's lots of cross resistance, but our last two, Pibrentosphere, really, for single position variants, there's no significant fold change, at least in vitro. You need double or triple mutants in NS5A to really see it move. Velpatasvir is better than, I guess, earlier generations, but it's also not as good, I would say, at least in vitro, as Pibrentosphere from a resistance profile. So what are our retreatment options? And again, I'll go through this pretty quick so we can get to the last elimination stuff. But we have two options now. One is soft Velvox. So that's a protease inhibitor, well, NS5B inhibitor, NS5A inhibitor, plus a pangenotypic protease inhibitor, 1 tablet once a day, retreatment regimens. Kathy took a lot of our patients here through Polaris 1 and got them all cured. But it works very well for retreatment. You see slightly lower rates for 1As and genotype 3, and in patients with cirrhosis still. So guidelines would recommend in a genotype 3 patient, say that has cirrhosis, that you're retreating to add ribavirin, not really based on any data with this regimen, but using analogies like what I showed you with soft-vel, some indications that ribavirin may improve responses. And then we looked at retreatment of GP failure. So I think there is still some question. In the Polaris 1 study, there were 2 genotype 3 patients that had failed GP, no genotype 1s. They were both cured, but we don't have a lot of data on GP failures. Are they any different? I mentioned they are going to have a more complex resistance profile, and they're going to have NS3 and NS5A resistance, probably both, where you really didn't have a lot of NS3 resistance here, protease inhibitor resistance. So are they any different? I don't think we know. This study looked at treating with soft plus GP and ribavirin for 12 to 16 weeks. All the genotype 1 and 3 patients in here got 16 weeks, and there was only a single failure. So still pretty high rates, including all the genotype 3 patients, but very limited amount of data. There's always questions about, does the resistance pattern matter at all? This is data from the Polaris study looking at soft Velvox, and even patients with double, triple mutants, they're very few, but there's really no indication that the resistance pattern matters, no matter what it actually does in vitro to Velpatasvir anyway. A lot of these patients have very high levels of resistance based on in vitro data predicted, but they still seem to do fine with the triple drug therapy. And it may be just, you have sofosbuvir plus a highly potent protease inhibitor that can knock out on any of these variants that have NS5A resistance, and the NS5A helps you with the other stuff that's there. I'll skip this. And then the only patient that failed was soft plus GP, was a multiply treated soft litiposphere first, had treatment failure, had both protease, and then when he failed his first treatment with GP, he had both NS5 protease, high-level protease resistance and NS5A resistance, and failed again on retreatment. There have been some other real-world data coming out about use of soft Velvox to treat GP failures. They're all small studies. They all seem to indicate it works pretty well. So I think that is a reasonable option. That for the patient I showed you, we fought for a little bit to try to get soft plus GP unsuccessfully, and eventually treated him with soft Velvox plus ribavirin. I added ribavirin for 12 weeks, and he's cured now. So my anecdote of one for a GP failure so far is that soft Velvox is probably a reasonable option as well. So this is, I think, interesting. So the new agents are much more pangenotypic, at least in vitro, but you'll notice in vitro for things like genotypes 3, 4, and 6, it's all 3A, 4A, and 6A in terms of our in vitro systems. Genotypes 4 and 6 globally are extremely diverse genotypes of hepatitis C. You can see it here. So this is the latest update kind of showing the provisional genotype 8, the newest recognized genotype 7, but here's 6 with over, I think now there's actually more like 60 to 70 different genotype 6 subtypes. And then genotype 4, next most diverse, a large number of subtypes. And so how does this broad diversity of the virus affect DAA treatments that were really screened in vitro based on in vitro replication systems, which took a single genotype or subtype within these? So how do they work? And there's some interesting data, most of it's from Southeast Asia areas, that there may be some potential issues. So Lodiposphere cephalosporin, it was known for a while that in vitro against, say, genotype 6E, essentially Lodiposphere had no activity. It was over 1,000-fold shift compared to genotype 6A. And so there's a little bit of data, some of this is from Vietnam and other places in Southeast Asia, that looking at soft Lodiposphere for treatment of genotype 6 with lower SVR rates. This study Raj Reddy was involved in, 64%. And again, 6E over 10,000-fold shift compared to genotype 1A in terms of Lodiposphere activity. But then you see some other studies that include this 6C through L, so they essentially lump everything in there, that showed pretty good SVR rates, 100%. So is it really the subtype, the prevalence of the resistant variants or polymorphisms in the subtypes? I don't think we know. Jean-Michel Potlowski and the group in France looked at all their DA treatments in France. France has a lot of immigrants from areas in Northern Africa where you see a lot of genotype 4. And they looked specifically at genotype 4R. And they had 27 genotype 4R failures. So that was an appreciable percentage of all their, that was almost all their genotype 4 failures were this 4R subtype. They didn't really have any failures with other subtypes. Most of them were not treated with what we would call pangenotypic regimens, so they got early regimens, so they didn't get soft Vel or GP. So I think that's a big caveat. But the interesting thing there, they saw even NS5B resistance develop pretty readily in this population. For 5 of 27 to develop cephalosporin resistance is pretty remarkable, where generally it's much less than 1% of other patients that fail with other genotypes. And then another study with Lodiposphere cephalosporin with only a 53% SVR in genotype 4R subtype. So I think there are some of these issues. There was just a presentation at EASL, the European Liver Meeting, looking at Africa specifically and genotype 1 non-AB subtypes. We don't see them very often. I think we had one genotype 1C maybe we saw over in clinic here. But again, anecdotal really, but they saw a much lower SVR rate, 75%, again with soft Lodiposphere in these non-AB genotype 1 subtypes. So I think as we start rolling out globally and talk about elimination using DA therapy, I think it's a strong argument for using truly pangenotypic regimens, at least soft Velpatosphere and GP, as we roll out. The last I'll mention, I think, and the most interesting and probably, I think, going to be the most problematic, though, are genotype 3. Genotype 3 is the second most prevalent globally. Somewhere around 25% of the global infection is genotype 3. And again, almost all the registrational trials, all you saw was genotype 3A. Less than 1% are going to be a non-1A subtype. But this genotype 3B in particular seems to be a problem in terms of DA therapy. So it's prevalent in Southeast Asia. Some data from China suggest it's certainly there. Thailand, 10% roughly was 3A. Myanmar, 30% had genotype, 3B. And then this was an in vitro study from China. They had about 600 genotype 3 isolates, about 70 were 3B. And essentially 100%, 96% have, it's essentially wild type for this virus. They have the A30K plus L31M. And in vitro, this is a group from the UK that looked at this in vitro, it causes essentially over a 10,000-fold shift in the activity for declatosphere, but belpatosphere as well, high level, and then elbosphere. Pibrentosphere for the A30K, L31M, it's about a 20 to 30-fold shift in its activity in vitro. I haven't seen any data with GP yet in 3B. I will say the manufacturer's a little reluctant to go into some of these places. I don't think they want to know what might happen. We've asked them, the ACTG has a minimal monitoring study, you guys know here, you enrolled, that is looking in different places, India and other things, and we've talked to them about an acute trial in India, and they weren't too fired up about seeing what happened. So I think this is a potential issue, and there is one study now with soft belpatosphere that showed only a 76% SVR12 just in 3B with soft belpatosphere for 12 weeks. If they had cirrhosis, it was a 50% SVR. Not many patients, but I think this is something certainly to keep an eye on, as really globally, soft belpatosphere is what most people probably are really talking about, as well as soft declatosphere in terms of being rolled out as an elimination regimen. Okay, so we're going to come back to elimination now. So this is Homi Razavi. I don't know if many of you know him. He's at the Center for Disease Analysis out in Colorado, right down the street. Has done a lot of good work in terms of trying to update global numbers in terms of just prevalence and incidence across the globe. And he generated this global cascade. So again, about 70 million viremic patients left at the beginning of 2017. And over 2017, they estimated about 20% had been diagnosed. So 14 million. But then as you start talking about treatment, only about 3% treated. And of those, the estimates generally about 90% cured. I don't think they had any data for that last part. So that's where we kind of stood, at least at the beginning of 2018, in terms of the global cascade. And remember, we're trying to get to 90% diagnosed, 80% treated. So ways to go. But I wanted to start with kind of a happy message, a good message. So Egypt, and I put here from worst to first in 5 years. So globally, Egypt had the highest prevalence of hepatitis C, depending on the age range and the segment of the population you looked at, somewhere around 14. This study, 10% were antibody positive, 7% RNA positive, so over 5 million persons. And they started, in 2014, they started a national treatment campaign. These were their sites, so they kind of strategically placed them. So I think Dr. Wakid made this presentation at that AASLD elimination meeting and kind of strategically placed them. So I think it was something like 95% of the Egyptian population was within 50 kilometers of one of these centers. And these are treatments they rolled out per month starting in September 14. So 50,000 treated, 80, 100,000 treated a month over this time period. It takes you down here, but you see it coming down, obviously. And so 1.5 million treated in about 2 years of their initial rollout. But then they saw, obviously they saw the numbers coming down. If you extend it out a little further, all the way till July of 18, they saw this really drop off and they were getting very few additional treatments. But by that time, they had treated not quite 2.5 million persons. He made a big point of, it was, what is this, $600 million. But they were starting at $245 a course for their treatment, the complete course. Now they're down to a place where they're using generic soft declatosphere for 12 weeks, and it's less than $50 a treatment course in Egypt. So prices have come down a ton in the United States, and so they're cost effective, maybe even cost saving, depending on how you look at it. But I think the question of is it still affordable is a much different one. So again, in Egypt right now, they're at $40 a treatment course, and they've done 2.4 million. But when they saw that drop off, they're like, we need to do something else to screen because we know there's more out there. So they started a national screening program, 3 phases, 5,000 sites. They trained 12,000 and then had them train, they train the next wave. Medical facilities, mobile units, it's at public transportation area. You just walk up and be tested kind of anywhere throughout Egypt or in major areas. So since the rollout, again, October of 18, it's almost unbelievable. I'm not sure. They said they screened, approaching 30 million additional persons in that time in Egypt. They found a 4% seroprevalence, so significantly less than the initial swath, with 3% that were viremic, so still 900,000 or so. Their cost for this whole program, supposedly $26 per viremic person identified. And so this is kind of their updated cascade. They think they're getting very close to having tested everybody or diagnosed, diagnosed everybody. This actually, some of this was estimate. The only numbers they had was through 2018, so where they thought they were about halfway there. But they're estimating sometime in 2019, 2020, they will have reached the 90% diagnosed. Linkage and treatment, they're estimating somewhere 87% and 85% cured. We'll see, but Egypt may be the first country with a significant hepatitis C burden to reach elimination. So I thought that was really fascinating. So in the United States, we have, I think, probably one shining example. Co-infection may be one, but system-wide, the VA. And Lisa Backus was kind enough to share this slide with me. But, you know, the VA estimated they had somewhere around 170,000 vets that needed to be treated. And this is where they've gotten from end of 13 till the latest data she had was just through the end of 2018. So you see a pretty straight line drop, but what they've seen, like in Egypt and other places, you know, to get that last little bit is exponentially harder in terms of effort and finding, and a lot of these patients simply don't want to be treated, don't want to come in. So they're somewhere, they think they're somewhere down around 25,000, but again, to get that last little part may be very difficult, but they've really done a fantastic job. At their peak, they were treating about 20,000 vets in a 6-month period, and that's, again, come down as there's less and less to treat. Yeah, Susan. Yeah, I can. She didn't mention that, and I don't know that they know or have data. Oh, sorry. Yeah. You even said that right up front. You did. So Susan asked if they know or there's any thought about how many of those last part might be reinfections. And I don't know of any data from the VA. I would suspect it's probably pretty low, just guessing on the VA population, but I don't know of any data. The one thing, you know, the VA obviously focused very heavily on birth cohort screening. And what you can see is that when they started their birth cohort screening around 2000, the prevalence in that population, when they tested them in the birth cohort, was 19%. When you come back in 2018, testing the leftover persons in the birth cohort that have never been tested, now they're only finding a prevalence, you know, down around 2%. So again, you identify a lot of the ones that are probably higher risk besides being in the birth cohort very early, and what's left are probably really ones that were not very high risk. Okay, so where do we go from here in terms of elimination? I'm just going to focus briefly on a few of these. I'm going to spend most of my time probably talking about what are the high prevalence and transmitting populations and what can we do to engage them and get them treated. A little bit about awareness and identification, and I feel like you always have to address cost and access. I really won't talk about the issues surrounding, you know, getting more providers. I think one of the things that is happening is simplification in hepatitis C treatment. That's going to be a big emphasis for the guidelines going forward. Is a whole new section that really talks about simplified treatment for a population that doesn't have cirrhosis. This is the first time they're being treated. How can you really pare down what you need to do to make maybe treatment more accessible for other providers? And again, over there, we're going to talk just briefly about corrections, injection drug use, and HIV positive. So Medicaid restrictions, we all lived through this. Restrictions based on fibrosis stage was the big one initially, with a lot of restrictions in place, most F2 at some point. And now we're to the place, this is even outdated by 2017, or the color code is wrong, because these are no restrictions, these lighter blue areas. Some have completely nothing. No restrictions, so that color code is off there. But there's no restrictions here in California by fibrosis stage, none in Colorado, and a lot of states now are not to that place. We're at A- in Colorado. You guys are a solid A here. I think that's because we still have counseling. There's no substance. They can be using substances, but they have to be in counseling, or it has to be documented that they're in some type of treatment program for that. Whatever that means, it's very loose. And we have a 6-month confirmation for chronicity. You have to have 2 RNAs 6 months apart, or show significant fibrosis somehow, and you can get around that. So we have some things left. The one positive thing in Colorado was all prisoners now get treatment for hepatitis C in prison. That was, of course, the ACLU threatened to sue the correction system, and then they quickly put $40 million into the system to treat hepatitis C. So now all of our prisoners in Colorado get treated, and there's no waiting, no fibrosis restrictions. Lucas, what are they? what are they treating with and how much does it cost? So they're treating with elbasvir/grazoprevir. I don't know how much they paid for it or what the cost is. They are giving the complete course to the prisoners. If they're released, they get the rest of their course. We had a 3-month period where everybody was scrambling. We work closely with corrections at Denver Health. We're kind of where they would come if they needed a higher level of medical care for most of the prisons and jails. And so they had reached out to us and their providers saying, you know, as you guys all know, a lot of times they have no idea when they're going to be released, and they're released, you know, within 24 hours when they know. So initially it was, my God, this guy was released. He doesn't have his medications. He's 6 weeks into his course. How do we do this? And it was literally just, they would get on the phone and we would say, just overbook him, come in the next day. And they would emergency put a Medicaid par in. Usually they'd have a break of 5 days. If that requires the patient to be on top of it, because they've got to really call. And that's just, I mean, you know, what are we doing here asking them to do that? So now they get their full course when they leave. We still try to get them in as quick as we can, but it has really helped quite a bit. Did you have another question? Yeah. Yeah. Oh, kicking stuff off.
I'll repeat
stuff.
it. The elbasvir/grazoprevir is not pangenotypic, which adds cost to you know, preparing for that regimen. So is there any discussion about changing the regimen?
Yeah, I haven't heard discussion. I mean, if they have a non-genotype 1 or 4 regimen, they'll use sofpilpatosvir, so they can get it. I'm just assuming they have an agreement where they got a much better price for elbasvir/grazoprevir, but they can access a pangenotypic regimen. But again, they don't use it for everybody. So, yeah.
Would you happen to know how many states are requiring prisoners to be treated?
I know Texas is one I had heard of recently.
What?
That they're going to start treating all their prisoners, which was surprising. I don't know how many states are going to start doing kind of widespread treatment. Yeah, I mean, you guys also probably heard about Louisiana. I know Christy Marks is down there. They signed the deal for the Netflix pricing agreement, so they have open access to hepatitis C therapy for everybody in Louisiana. They negotiate with the drug company and say, we're going to treat at least this many and we're going to give you this much money. But if we treat more than that, we get the right, you know, that's all we're paying and we get as much as we want. Yeah. And that's the way other countries have done this. Australia being the shining example, right? They waited till there were multiple regimens. They negotiated very strongly and they have open access now for everybody in paying a base amount and guaranteeing a certain amount of money and a certain amount of treatments. But above that, they don't pay additional. So we just talked a lot about cost. I think we should skip this really. Again, affordability is really the issue, especially globally. It's not cost effectiveness. Although recent analyses, this is JAG, Chotwal, and Harvard, they're probably actually even cost saving, especially if you consider a societal perspective. At least that's their estimation, as the costs have come down now to the range of 20,000 plus or minus for a course of therapy. You look at increased work productivity and other types of things, as well as avoiding all the medical complications. Probably is cost saving actually to treat somebody for hepatitis C, but again, that still doesn't necessarily mean it's affordable. All right, so now we're going to talk about the bad stuff for the next 10 minutes or so, I think, or less. So we have a little time. So going the wrong way in the United States. So this is acute hepatitis C infections. These are the number reported, about 3,000 reported to the CDC. They essentially multiply by 14 to think that's the number that are actually out there. So it's been a 300% increase since about 2010. The estimate for 2016, 40,000 acute cases, but look at this range, 30 to 150,000 new infections. I think it's instructive to look, if you look state by state, the average was 1 per 100,000 nationally, acute hepatitis C infections. Massachusetts was 6 times that, and they have the best reporting system. And they also don't use the CDC definition. They use, I guess what most people would say is a better definition of acute hepatitis C, maybe a little more liberal in terms of the definition, not the state. So I think it's much higher. I think it's probably closer to the 150 range. It might even be higher than that. And when we've seen it in Colorado, this is the Denver metro area, the 5 big counties kind of around Denver, the city itself. And this is just looking at under 30 new diagnoses of hepatitis C. And across Colorado, you can see somewhere around 2012, 2013, going from what had been pretty steady, about 300 new cases reported to Colorado Department of Public Health in under 30 every year. And you see, you know, the year-over-year jump. to 900 in the most recent year they were tracking, which was 2016. And Sarah Rowan in our division works with public health closely. So clearly is going up in the young population. That's a whole shift, right? A whole shift in the demographic that we should be testing. And so we need new and expanded screening approaches. The unidentified injections, they're not generally engaged in primary care. They're certainly not in the birth cohort anymore. Several emergency departments have done screening and generally find somewhere around 15% seroprevalence in populations coming into the emergency department. So this is really just a way for a little plug. Jason Halkus and Sarah Rowan. Jason's an emergency department physician. He's done a lot with HIV screening, but they're going to start a program, Detect HCV, for universal screening in our emergency department. They're going to do it also in Alabama, I believe. So 2 emergency department universal screening, and then randomized to essentially an intensive linkage to care package versus kind of standard of care, and see what they get, and then look at cost effectiveness of this. But I think we need new screening approaches for sure. Oh, surprise, Susan has a question.
So purely self-interest. So we have a birth cohort screening in our ED, and we're at about a 10% seroprevalence. We want to go this direction as well. Is universal screening reimbursable?
So good question. Not necessarily yet. I mean, it depends on obviously what insurance they have and stuff, but it's not a U.S. Preventive Services Task Force. There's no grade recommendation for that, right? The birth cohort is grade B. So it may not be, or it is not mandated to be reimbursed. Let's put it that way, right? We think for our Medicaid, it would be reimbursed populations. Depends. If you want to get tricky, you can probably identify a risk factor which would say they should be screened, but that's hard when you're trying to do a bunch, right?
We're just afraid our overlords would get mad at us.
Yeah. And this is just a cost effectiveness analysis. Doesn't say anything about reimbursements that Joshua Barokas and Ben Linus wrote that was in CID, just looking at different scenarios. But it looks to be cost effective to screen 18 or older. I mean, obviously, we probably should be going lower. There's nothing magical about 18. There's obviously populations at risk in adolescents as well. And they found about 250 additional infections and 280,000 more got treated. This is, you treat more than you find because the ones you were going to find before you're finding earlier in these models, right? And so they have more time to be treated. So you actually end up treating more. So this is what we're doing in probations right now. So this is a retrospective analysis. So we're working with Denver Adult Probations, which has probably about 7,000 to 8,000 probationers here. Just to remind you, probationers are the largest correctional population in the United States by far. So probation is somebody that gets arrested, is charged with a crime, in this case a felony, but they're not put into prison, right? The judge, they come before and their sentences, they're not in prison, they're put directly to probation. They have to come in and be followed weekly, whatever, and stuff like that, but they don't go through the prison system, so they aren't able to avail themselves, that's what I was looking for, of the health screening services that typically occur in prisons at intake, right? Which generally include HIV and hepatitis C screening. So they're by far the biggest population than those that actually go to prison, come out of prison on parole or jail, or smaller groups. But we looked retrospectively at about a 2-year period, about 9,000 probationers, and then just did probabilistic matching, looked in our EHR, and we're looking over at the university as well. And about 78% that were on probations interact with Denver Health. They'd been through the emergency department somewhere. Of those, only 12% were tested for hepatitis C, despite the fact they essentially all have risk factors for hepatitis C and should be tested. And then of those, a third of those that were tested were actually RNA positive. And then we looked through their cascade essentially, and as you'd expect, dismal numbers in terms of those that are actually then tested and go through treatment and achieve SVR. So that was the retrospective, meant to be a baseline. What we're now doing is a prospective screening program at probations, HIV and hepatitis C point of care testing, phlebotomy, for confirmatory testing, not done on site obviously, but that comes back. And then linkage and navigator support. They get an appointment within 2 weeks to be seen in the clinic to come in, and we'll see. We've only screened about 150. It was the CDC program all over again, PTSD, in terms of just getting it up and running in a new place. They're not sure about what we're doing there. They're not too happy to be tested when they're coming in for probations. They want to get the hell out of there. So it's been really slow and pick up, but it seems to be picking up. We tested 40 last month, so that was better. The Australians, once again, are outclassing us in terms of what they're doing. So this was persons who inject drugs, 15 sites, they enrolled 1,000. This is an observational cohort. Marginally housed, all the other risk factors you'd expect. They're doing this actually used the Cepheid system, and they're doing essentially point of care RNA testing. Now, it still takes 90 minutes or so to get the result. So, you know, hard to get people to stick around, but they essentially did pretty well through linkage, and they had 59% treatment uptake in persons who inject drugs. That's pretty darn good. Again, they tried to do it all in that one visit, although it took 2 hours or 3 hours to get them through everything, but they would eventually start the treatment right there at that visit if they stuck with it. They estimate now they've decreased the prevalence of hepatitis C from about 57% in their persons who inject drug population in Australia, to cut it in half with just about a year and a half or 2 years, to 27% right now, I think. So again, it can be done. It takes a national coordinated effort, which is what we cannot do. I just mentioned this. Iceland probably has or is going to eliminate hepatitis C in the next. They have 340,000 people in Iceland, and about 0.3% had hepatitis C. So they only had 1,000 or so to treat, but they're getting close. But homelessness is just one of the things we deal with that I think is probably the most problematic. It's not the injection drug use necessarily. We do pretty good at getting them on medically assisted therapy or opiate substitution therapy. All those things have been shown to improve rates. But I just put this up here because this study, when they looked at their program in persons who inject drugs, the only factor that came out as a risk for not attaining SVR was being homeless. Wasn't injection drug use in the last week, the last month, nothing else. It was just homelessness that had about a twofold risk for not attaining SVR. So I think that's another thing we need to tackle as we go through this. I'm going to skip over this. So these are studies that I'm skipping over are talking about treating acute hepatitis C and HIV positive MSM. We've seen several demonstration projects that in a short time you can decrease incidence and prevalence. What I'm interested in, we're designing a study in the ACG, is treating acute hepatitis C. Not clear that using non-DAA-based therapies, you really get much benefit by treating in the acute stage. This is some of the data that's out there. Using soft fludiposphere for just 6 weeks was associated with about an 80% SVR, although if you take out the ones that were lost to follow-up and didn't have virologic failure, if you only look at virologic failure, it was 87% success rate with soft fludiposphere for 6 weeks. Their viral load at baseline seems to be what predicts the failures. Most all the relapses had high viral loads when they were retreated. There was just a study looking at GP. So GP is, again, soft fludiposphere, we have a small population you can try a shorter therapy of 8 weeks, but GP, almost everybody is 8 weeks, including cirrhosis. And it's pangenotypic. So there's a recent study at EASL that looked at just 6 weeks, 30 patients. Almost all were MSM and almost all had HIV co-infection. Almost all of it was sexual transmission. It was Australia, New Zealand, and the UK. Mostly genotype 1. But they had a 90% SVR rate, but if you take out, there was only one virologic failure. There was a death and a loss to follow-up. So per protocol, looking at virologic failures, 96% was 6 weeks. We were very anxiously awaiting this data because we've been designing this study in the ACTG, the PURGE-C study, which is going to look at 4 weeks. And it's being supported in part with the pharmaceutical sponsor, and they said, if this 6-week study that's going on in Australia right now doesn't look good, we're going to pull the plug. So luckily it looked good. So we're going to go ahead. This should open July, August through the ACTG network. Hopefully UCSD is going to enroll a few acute hepatitis C's here. It is different. This 6-week study was very liberal, and they had patients, you could be infected for up to a year after, with documented infection for at least a year. So they were early infection. I wouldn't call them acute. So we're really focusing on trying to get them very early. 6 months is the longest. We want to get them in as soon as possible. As soon as they are diagnosed, there's no waiting for anything. Get them in and start them on treatment because, I mean, I think we're pushing the envelope here to get to 4 weeks. I think everybody thinks not just from a cost standpoint, but from completion, it's one fill. You're 4 through 4 weeks. So if it works, I think it could be really great. But I think one of the key things is you're going to have to find people early, and that will be kind of tricky as we present the data. And if it starts to look to roll out, it's going to have to be clear to people how you have to identify, because I think you are going to run the risk if they get to chronic that 4 weeks is not going to work for everybody. It probably will work for a significant portion of even chronic, but not high enough. And if you do this, there's been lots of different studies. This was the Dutch, treating acute hepatitis C in high-risk populations like HIV positive MSM, which are probably the highest risk for reinfection. is actually looks to be cost savings based on, now they used a very, well, not a very high, this has been found in some studies, reinfection rate, but is probably cost saving. All right. This is going to be the last slide I'm going to talk about. So one of the questions is, we know there is a lot of transmission of hepatitis C and HIV positive MSM, much of it sexual transmission. The question has been, is this going to cross over into HIV negative MSM? And we see some, obviously some of the PrEP studies, long-term follow-up studies, you see acute hepatitis C infections. So this looked in, in France, Lyon, France. They looked at their population of HIV, of hepatitis C, acute hepatitis C and MSM. And what they saw just by the color coding, so these were clusters that had been going on for a long period of time, some back to 2000 they had clusters, and they looked in the last couple years, the red infections are going to be in HIV positive MSM within these clusters, and then the green are HIV negative MSM that belong in that cluster, so there's transmission between those two groups. And so what they, anecdotally kind of, but since 2015, they've seemed to see a real increase in HIV negative MSM. Most of them are on PrEP in this study that are getting incident hepatitis C infection. This is just one of the clusters. And there's another one from the Swiss HIV cohort as well, but I won't talk about that. Jill, yeah.
Sorry, we're talking about this within our study. There seems to be something different going on in Europe because I mean, we just analyzed, I think it was 605 people, no incident infections in our cohort, but we did just have our first new Hep C at our PrEP, in our PrEP services, not our PrEP clinic, PrEP services. But that's obviously anecdotal, but that's our first patient of, I don't know, 120 or so, but definitely not in our original cohort of,
One of the slides I skipped over was Daniel Fear's study in New York, where they seem to see a lot of sexual transmission, a lot of reinfections. I don't know, you think the sexual practices are different? Less chemsex here, less, no, tons, right? Meth and...
I think we're going to have to try to figure out why it is happening so differently, in different populations.
Okay, I know people have to go to clinic, so all I'm going to say is the United States, Homie was kind in putting us yellow here. The most recent iteration, we're now red, but we're beyond 2050, well beyond if we're going to eliminate hepatitis C again. Egypt's going to, probably a big country. Iceland, yes, they'll do it. Australia will be the next large, probably. They'll make it, but the majority of countries won't make it by 2030, probably, at least not the way things are going now. Okay, these are just some concluding thoughts, but you guys can read that. But we're right at 9. I don't know if we have time for any questions, but that's it. Dr. Schooley.
So the dendrogram you showed with HCV diversity was drawn taking the whole genome into account. I take it. Is that right? Or just the?
It's not. Most of those are not whole genome. Most are going to be NS5B
That's
sequences.
what I was asking. Yeah. Okay.
Yeah. Standardly, that would be the genotype and subtype assignment.
Just that, okay.
Yep.
If people, are there enough data available to look at individual drug targets in terms of diversity trees to see if that is more predictive of utility?
Just purely diversity, not specific amino acid changes.
Yeah, and you see what I'm talking about?
Yeah. I don't know. I guess you could argue NS5B, but it's the diversity in NS5B probably doesn't really affect nucleotides, right? So it'd have to be NS5A. I don't know that I've seen the dendrogram with just NS5A diversity, although I think it would look pretty similar, but I guess I don't know that for sure. I think that in general, if you look at the whole Hep C genome, the rate of diversity in NS5B and 5A are pretty similar. The envelope proteins stick out as being extremely diverse, and then core and less so. Yeah, I don't know about protease at all, and there's not going to be as much sequence data dedicated to protease. Yeah. Oh, I forgot my acknowledgments. Where Kathy already left? Here's everybody. Yeah.